for Bhubaneswar. Lot of excitement.
Not only excitement, it will be a dhamaka. I'm telling you.
It will be a big
Ankit is
dhamaka.
there. My bhai hai, who is organizing secretary.
Yes.
कितने बार बोला अमृत, पहले से पढ़ाशुना कर, स्टडी पहले से कर, लास्ट मोमेंट के करना.
Are we good to go?
Yeah, we are good to go. Just have a countdown. 5,
Yes,
4,
sir.
3, 2, 1 and then start. ओपी सिंह दादा भी आ गया.
ओपी ज्वाइन किया.
ये बहुत अच्छा है गौतम दादा.
हाँ, यस. ओपी सुनते पाচ্ছি ना, ओपी अनम्यूट कर. सुनाई नहीं दे रहा है ओपी.
अनम्यूट करो.
हेलो हेलो.
हाँ,
वेलकम वेलकम.
अभी ज्यादा
क्रिएटिंग प्रॉब्लम most probably. हाँ.
Sir, good evening.
Good evening. Good evening.
Pratik will just give us a go ahead any moment, sir. I'm just waiting for his green signal.
Hello. Yeah. Yes, sir. Once the slide is gone, so the session will start. Okay. I'm sharing a slide. Yeah.
Yeah. Yes, Pratik. Yeah.
Yes, sir. Once I remove the slide, the question will be like, okay.
Okay. Yeah.
Yeah.
Good evening, respected doctors. I'm Rup Kumar, General Manager Marketing from Linex Laboratories. On behalf of Linex Laboratories, I take immense pleasure in inviting all of you wholeheartedly for a learning and sharing session on new horizons in the management of depression, chaired by none other than Dr. Gautam Saha, sir, moderated by Dr. G. Prasad Rao, sir, and sessions covered by Dr. Pramod Kumar, sir, Dr. O.P. Singh, sir, Dr. Amrit Padjoshi, sir. I also welcome all the participants and moderators, chairpersons in the hybrid centers, in 18 hybrid centers across the country. Dr. G. Prasad Rao doesn't require any introduction, even in the global psychiatric arena. So without much ado, I would like to hand over the session to Prasad Rao, sir. Sir, over to you, sir.
Thank you, Rup Kumar. In this wonderful session, as I understand, more than 2,500 people have already registered, and I don't know, lot many. We have 20 centers, hybrid centers across the country, north, south, east, and west. It's my real pleasure to invite the chairperson of the evening, Dr. Gautam Saha. Dr. Gautam Saha, I think, I don't know, if I start introducing him, it might take quite a lot of time, but I will definitely do justice by inviting. He's one of the most energetic, efficient, ebullient, and really working till the end during both terms. During my term as a president, I think he was one of the most, you can say, backbone of the IPS activities along with me. Along with that, this is something. He became a national leader of Indian Psychiatric Society, and now he is the president for the SAC. He has presented in multiple congresses, both in the World Psychiatry and also in the National Psychiatry and SARC Psychiatry. And you find him wonderfully, beautiful faces of his family too on the Facebook, which gives us energy every day. Welcome, Gautam Saha. Over to you for your chairperson's remarks, please.
Thank you, Dr. G. Prasad Rao. Yes, I know still we remember our tenure in IPS when you were the president. I was the general secretary and I learned a lot. And after that, I became the president of the Indian Psychiatric Society. Thank you, Dada, for being with me always. What I'm telling today's topic is really fantastic because you know that depression, when you're talking about the depression, if you consider all the mental illnesses, whenever you stuck to any mental illness, any specific mental illness, I think depression is the toughest to overcome that. In fact, any psychotic illnesses or schizophrenia, whatever it may be, but when you stuck to depression, not responding to medications or other mode of treatment, then we are really in a very bad shape. So, till now, we are searching for a better antidepressant. There are lots of new antidepressant came in the market. And also in the armamentarium, we have got so many antidepressant till now. But before, when we did our post-graduation, before that only 2 or 3 good antidepressants. In fact, after TCA, only the fluoxetine came first. But now so many antidepressants are there. After that, neuromodulation and other methods are there also. But still we are searching a very ideal antidepressant or very good antidepressant till that. And now we are getting a new molecule, you know, that vortioxetine. It is not a new in the Indian market. Initially, it was marketed by only single multinational company, but now it is available in India by the Indian companies also. That is a great, with a very much lower prices. Price was very high. That was, we have to restrict our use of vortioxetine in few people only. And there are some conditions, as our experience goes, as my personal experience goes, the vortioxetine is very good in the geriatric population, depression with anxiety disorder, and patients who are facing sexual side effects with the vortioxetine, with the other SSRIs, vortioxetine there also acts very well. And in fact, sometimes in the resistant depression, where we are not able to use the venlafaxine or other antidepressant medications, there also vortioxetine is really beautiful as far as my experience goes. So I don't want to explain because there are 3 eminent speakers are with us, Professor O.P. Singh, Professor Pramod Kumar, Professor Mdd Patient. 3 of us are very eminent speakers and people are waiting to listen to them. So by this, I want to stop here and over to moderator, our Dada, Dr. G. Prasad. Thank you.
Thank you, Dada. It was so clean and precise. I think you hit the nail quite on the most important spot. One thing is it's definitely new in the horizon, mainly because, and as you see in this presentation, you will come to know what is new apart from the others, apart from its reintroduction into this country. But more important, I think this being an experience sharing session, I think we have wonderful speakers, one after another. And I'll start initially with Pramod Kumar. Again, Pramod Kumar, I have the distinction that we both work together in the Indian Association of Private Psychiatry. Again, we still remember the way he organized the IAPP conference when we started knowing him. He is a very astute clinician, quite novel in his approach, and quite forward-looking all as well. He has been in the leadership of Indian Psychiatric Society in the North Zone, IAPP, IABP, that is Indian Institution of Biological Psychiatry, and he did present in the World Congress, including at that time the novel ketamine in elderly, as you can see here. We both presented together in multiple international congresses, including I remember correctly, starting with London and then also in the United States. Pramod has a knack of presenting technology, and today he's going to talk on the novelty of vortioxetine. Pramod, without much ado, you're going to talk. Then I will introduce each speaker one after other as the time comes. Let us start having Pramod Kumar presentation.
Thank you, sir. And can you confirm my audio?
Yeah.
Okay. Now, and I thanks Linux for inviting me to be a speaker for such an interesting topic. And more important than is my best friends and my chairperson, moderator, speakers. I can tell you the psychiatrists, they are the doyens of psychiatry in private practice. I can assure you. So what I'm going to talk about on vortioxetine, and can I have my slides?
Kumar, slides please.
This is a molecule, as Dr. Gautam Shah was mentioning, that the depression is actually the bread and butter of any psychiatry. Most of the patients, if you see, almost 20% of the patients who visit us in our clinic, they belong to this particular disorder. I have been, this molecule is new to many people, but not exactly new to me. And next, please. Yeah, please go ahead. So whenever I start using any molecule, I have my own style of deciding whether I should use it or not. Just for introduction, Neurotransmitters was introduced in India in October 2018 and became available in Chandigarh in February of 2019. I started using it in 2019 April after thorough review of literature. Till now, if I go the rough estimation, I've used it in about 700 new patients, and my prescriptions volume, including old and new, is more than 8,000. And this I have confirmed through some kind of a, from the pharma, the molecule which I'm using. When I started using, I did my own research on this molecule. And when I started collecting socio-demographic, clinical profile, PHQ, neuropsychological assessment, because this was mentioned that this is a molecule which work on all the neurochemicals, and it is a multimodal and a designer antidepressant kind of thing. So my initial experience with 6 patients whom I followed up longitudinally. So I collected the data, I presented, I submitted my abstract to AP annual conference, and then in 2020, and which got cancelled. And subsequently, I increased my volume to 30 patients, longitudinal data of 30 patients. And this was presented at APA annual conference, this whole data. Next, please.
Next slide, please.
Yeah. So this was the poster which I presented at APA annual conference, and I'm not going to discuss the research evidence, but this is what I'm just trying to say. This is how I confirm my own decision before I use any molecule. Next, please. And this was the presentation I made on May 3rd of 2021. Next, please. So these are some of the studies, very important and landmark studies, which were done on vortioxetine before that got introduced into the international market and then subsequent to Indian market, and how they got the license to sell it in India. And these are the various studies. I'm just going to go quickly on this. So this was a double-blind study. Next, please. Then again, a randomized double-blind placebo-controlled study of vortioxetine cognitive functions. Next, please. So you can go quickly on these slides. So there are about 10, 11 studies which are there on vortioxetine, and very important studies which I would recommend to each one of the person to read it, and which gives you the confidence to use this molecule. Okay, and this is how I got the confidence to use this molecule in my patients. I'm going to talk about, yes, please stay over here. I'm going to give you a case summary, okay, because this was the discussion which my moderator, Dr. G. Prasad Rao, has asked me to discuss the case. And then there are other speakers who are going to discuss the other aspects of complexity. This was my, I would say, one of the very first patient I can say in. So NK, 31-year-old female, graduate, married from upper socioeconomic status family and nuclear family from Chandigarh, but originally she's a citizen of US. So she was visiting India during that time. She came to my clinic along with her mother in April 2019, and she complained of sadness of mood with decreased interest in day-to-day activities, decreased sleep, decreased appetite, and loss of weight. She also reported lack of concentration and diminished recall. She denied suicidal thoughts, and there was no history of manic episode, substance abuse, epilepsy, OCD, or any other psychiatric illness. There was no history of any medical illness or any history to suggest organicity. Next, please. She denied any past history of psychiatric illness. However, there was a history of alcohol dependence and depressive disorder in both the parents. And both the parents were seeing me for their treatment before she joined me to treatment. There was also a history of depressive disorder in maternal grandmother, aunt, and one of the maternal cousins. So there was so much of a genetic loading of this illness, and all of them were under my treatment. All the family members were already under my treatment. So MSc reported her to be conscious, cooperative, aware of the surrounding, eye-to-eye contact could be made, but she had decreased volume of speech and retarded psychomotor activity. Effect was suggestive of sadness with decreased range and reactivity, denied any delusions or perceptual disturbance. She was oriented to time, place, and function with decreased attention and concentration. Insight and judgment was considered. This is standard. How do we make a case presentation? Next, please. So she was diagnosed as suffering from moderate depressive disorder with somatic features. So she was first thing which I do with all my patients. She was counseled about illness, that what kind of illness she's suffering from, the treatment options, the course and prognosis. In the very, very first session, this is discussed with all my patients. And she was very categorically in saying that she refused to take antidepressant due to weight gain, drowsiness, and slowness, as is experienced by other family members. So when her mother was also under my treatment, she also says she doesn't want a medication for her daughter who lives alone in US, and she wouldn't be able to manage herself. Then discussion went further, and she was discussed about the possibility of corticosteroid and its side effect profile. She asked about the literature. She's a well-read person. She asked about the literature, which was shared with her. All the articles which I shared with you, those were also before 2019 article. They were all shared with her. She agreed to try medicines. Otherwise, she says she would like only counseling. When I say she had already undertaken counseling sessions in US before she joined me in treatment, her symptoms were not improving at all, and she was not convinced whether she should continue counseling or not. And when she talked to me about counseling, she wanted to try another aspect of counseling. And she also mentioned that she would try only once. If the medicine wouldn't suit her, she would not try the medication for the next time. Next, please. So she started on vortioxetine 10 milligram once a day and advised follow-up after 7 days. She reported improvement by about 10 to 20%. She developed confidence and continued to improve gradually, even in the cognitive symptoms. She reached pre-morbid state within 3 months. She continued to take medicine for almost 1 year, and it was stopped after that. However, she continued counseling sessions till now. The last counseling session happened with her just 3 days prior. She went back to USA in 2020 and continued to maintain recovery till now. She continued to have counseling. She got married last year, which she refused earlier, fearing divorce due to illness, which has happened with her, one of the maternal aunt, who was suffering from depressive disorder, and she was under treatment. She rejoined her work in New York and is currently the vice president of a very prestigious multinational company. And she's maintaining her green orbit state, and she is very, very regular with her treatment. She was very regular. She is maintaining her counseling sessions as per the calendar. Next, please. So what does this case give? First of all, this was one of the earliest cases which I used vortioxetine, and that gave me immense amount of confidence that this molecule, beyond the research, beyond the clinical, that clinical evidence is strong and gave me the confidence. But how to handle antidepressant resistance? Many patients whom we see in our clinic, they are not very keen to take antidepressants, especially those literate people who are Google literate people. So we have to have our own evidence. Because when I started, I did not have the clinical evidence of experience. I had the research evidence. So choice of antidepressant depending on the person's own profile, that is also important. And what should be the dose? What should be the side effects? What should be the duration? What should be the improvement in cognitive symptoms? I think when we discuss all these issues with our patients, we should try to address all these issues in the very beginning itself. Never tell your patients that this is a guaranteed kind of a medication and which is going to improve each one of them. Because my initial research, which I did on 6 patients, that did not give me, but that was a 6-month, rather for 10 weeks follow-up study. There were patients who improved in cognitive symptoms. There were patients who did not improve. However, there was no worsening of the cognitive symptoms. So that time the cognitive symptoms, whether they improved or did not improve, that confidence was not there. So this case was very, very important, and it gives me almost 3 years longitudinal follow-up with this. So I can go to the next case now, please. And this is another very interesting case which I'm going to tell you. Mr. AG, who's a 38-year-old married MBA senior investment advisor from upper socioeconomic status. He consulted me at my clinic in February of 2020. He visited along with his wife and reported almost 15-year history of mental health issues. His current problem was sadness of mood, anhedonia, anxiety, insomnia, weakness, loss of libido, decreased attention and concentration, inability to go to work. And he says he would prefer to die rather than being sick. His wife reported marital issues as he would indulge in multiple relationships with females at workplace and otherwise. During the phases of excitement, she decided to leave him after he recovered from the current episode, which was going on for the last 2 months. Next, please. He started his treatment around 15 years back at institution with depressive episode. He switched into manic episode after starting antidepressant fluoxetine. The very first time he got into manic after the use of fluoxetine. And over many years, he has been tried on divalproex, oxcarbazepine, lamotrigine. And he manifested side effects with all the above medication and stopped on advice of psychiatrist. He never stopped any treatment of his own. He always discussed with his doctors and was very regular with his treatment. And he continued to have switches into both mania and depression. The most serious side effect was Stevens-Johnson syndrome with lamotrigine, which was treated after he was hospitalized. He continued to have a regular follow-up and treatment as per advice. So despite sickness, he completed his studies. He has done his MBA, joined as an investment advisor in various capacities. His major problem at workplace was his promiscuous behavior. He got many warnings from the various investment companies. He reported it always happened during that manic episode. His work skills always allowed him to float in his job because there were other behavioral issues. And unfortunately, none of the complaint was lodged against him. That's why he could survive those things. Next, please. So he consulted me after going through my reviews on Google and came just for one option. He mentioned it very clearly that I'm not sure whether you could be of any help to me, but if there is an option, discuss with me. He was assessed clinically, biochemically, neuropsychologically. So he was diagnosed as suffering from bipolar affective disorder. A comprehensive psychoeducation session was done, wherein all options were discussed. And in fact, whatever medicine I was telling him, He had already taken that. In fact, his list of medication was much more than what I intended to discuss with. The option of vortexutin was disconsidered and it was told that it is recommended only for major depressive disorder. It is not recommended for affected disorder. However, considering switches and side effects can be tried in your case, he was offered full literature and advised to take time along with his wife to decide. He agreed after a few minutes, and this was recorded on his case file. His consent was recorded that this is a empirical trial which I'm going to do with vortioxetine. I'm not sure whether it will lead to switch, whether it will lead to side effect, but this is an option as of now with us. So let us see if we can exercise that option. Next, please. He was started on tablet vortioxetine 10 milligram once a day, along with clonazepam 0.25 and 0.5 at bedtime, along with vitamin D3 and B12 as his reported was suggested. He came for follow-up after 7 days and reported improvement in depressive and anxiety symptoms both. And he's maintaining well on the same dose, 10 milligrams since then. Now, I started in last year of February, okay, and still now it is being continued. He improved in all spheres and reported no side effect. Most satisfying, which he reported to me, was his no sexual side effect and his cognitive functions had also improved. And there is no switch as of now. So with till this time, no side effect and no switch with this molecule. Next, please. So if we like to discuss this case, so first of all, off-label indications. Like Dr. Gautam Saha was saying that depression, anxiety, OCD, there are so many off-label indications wherein vortioxetine has been tried. But if we go by the approved indication, it is only major depressive disorder. So off-label indications, if you have to go into that, it has to be with the appropriate discussion with the family. Sexual side effect. With this, in my experience of writing prescription for about 700 patients, I have encountered sexual side effect in less than 1%, not very rare kind of a side effect. I have seen issue of switch is also important to understand. Till now, in my experience, I've never seen anybody who was put on vortioxetine had gone into switch into manic episode. Next, please. If a moderator allows me, there is one more case which I can discuss.
We'll stop here, Pramod. I have one or two quick questions because I think the two questions the two cases you presented, and I loved the way you presented because it's an experience sharing and you have given two classic different examples of one MDD and one bipolar D. My own question to you would be is, in the large experience of so many cases, what is your recovery rate? What is the improvement on the cognitive symptoms? Because this is an experience sharing, so that would help the other doctors. There are a few thousand doctors listening to you.
Yeah. So as far as the efficacy of this molecule is concerned, I have started seeing improvement within the first week itself, and recovery continued to grow gradually. And most of the patients would reach to their premorbid state in less than 12 weeks time. So that is my experience with most of the patients. I would say more than 90% of the patients, I would say. Now, the second is, as far as the side effect profile is concerned, very favorable, I would say. I've never withdrawn any patient till now whom I have started on this treatment because of the side effect. Now comes the third question, which you say, just cognitive symptoms improvement. You know, I would say in my clinic, most of the patients which I see in my clinic, they belong to upper socioeconomic status. I would say more than 80% of the patients belong to that category. And cognitive functions is very, very important in especially in this particular class. And this is one of the reasons I started using this molecule, and it gave me till now, you can see, writing more than 8,000 prescriptions for patients. I got so much of confidence on improvement on the cognitive functions with these patients. That is the reason I kept going on these patients. Now, when I look at the my own research of 30 patients, it also suggested me improvement in cognitive functions very soon, and that continued to remain maintained during the whole process of recovery.
Thank you, Pramod. I'm sure you would have answered a lot more questions, but I think you have engaged with some important social activity. Thank you for your participation in spite of your busy schedule. Now I would request Roop to unshare the slide so that I can present mine. Thank you, Pramod.
Thank you very much. Thank you.
Yeah, you can stay. Now I'll take a little time to present my detailed presentation on what is new here. And most of you know this. The basic topic is this is a new horizon. And my own experience as I learned both as a clinician and also a person who was involved in the drug trials, I'm going to present in the next 15 minutes. I do share with you my own commitment with all these companies as a speaker and as in the drug development research. To me, the depression is something when I started about 3 decades back, it is something like this. Depression is about a quarter low of serotonin. Schizophrenia means a bit too much of dopamine, but that's just not how a brain functions. The brain isn't a bowl of soup. And to add to the problems, as correctly told by Gautam Saha and also Pramod, that his relatives and the family think that there's nothing wrong with him except he's just unnecessarily worrying. Ladies and gentlemen, depression is probably the most common mental disorder. Globally, more than 300 million people suffer from depression. And about roughly 4.5% of population have a depression across the world. A lot of multiple figures converge into this around 5%. Take it major depressive disorder or a bipolar depression together. And our own Indian statistics, especially the most recent survey published by the 2016 by the Government of India, done by Government of India and published, actually talks more or less the same figures. The most important thing which I would show here is what's happening is that most patients come to us during the acute phase at this point of time. And they have a varied amount of responses and remission. This is a famous slide originally showed by Kennedy and others, which talk about that an episode is not totally cured many a times. And what I want to really stress is this data which now shows cognitive symptoms may persist much beyond the recovery of a depressive episode. And they occur in roughly 50% of the patients as shown in this slide. And roughly 94% of patients who do not recover do have cognitive problems. In fact, our own treatment goals in depression have changed from time to time. In 70s and 80s, we talked about reduction of symptoms, and we used to use scales like MADRS and HAM-D to say 50% reduction is sufficient for a response. Now, remission is a criteria used in 1990s onwards till 2010, when they talk about much HAM-D scores reaching 7 or less. Finally, today, from 2010 onwards, we are looking for molecules and psychotherapies for a functional recovery. But what are the real needs, unmet needs in depression? I think this OP Singh is going to talk a little bit more in his presentation because he's going to talk about the evidence in depression. But these 4 or 5 important side effects, the weight gain, sexual side effects, sleep disturbance, discontinuation syndromes, are quite common with all the existing molecules. I'm also going to show you, for example, the most famous study, the STAR-D study, the sequential treatment alternative. Only 1/3 responded to the first molecule. 67% of them remained depressed even after three more trials. And the most important, and this is where I thought the persistence of symptoms, and here you see in this large 2-year follow-up study, worthlessness, hopelessness, eating disorders, and all come down. The 2 important symptoms which remain, 40 to 50% of patients is cognitive symptoms and core symptoms of depression. They remain for quite long. So the patient enters into a residual symptoms persisting up to daily, and patient experience low mood with not a total recovery, and that further increases the relapse. So this cycle, and most important today, we talk especially in depression patients, the family, the work, and social life, all the three domains, and of course the personal domain, as McIntyre keeps talking, that this is the domains, unless they are improved in cognitive dysfunction, the patient is not totally cured. Having said that, the most frequently discontinued reason for the antidepressants is not so surprisingly for every one of us, is the four common side effects: weight gain, sexual side effects, sleep disturbances, either excessive sleep or disturbed sleep, and discontinuation syndrome. And this is found by multiple studies even in the last 2 decades. Having said that, gastrointestinal symptoms in SSRIs, weight gain occurs in 35%, decreased sexuality occurs roughly around 47%, and insomnia occurs in 36%. So multiple bothersome side effects, especially in the study by Goethe et al. Published in 2007, talks about side effects. So what are the new horizons we are looking for? We are obviously looking for a molecule which beats the average of 33% remission rate, which also beats the residual cognitive symptoms, which also has lesser side effects. So with this in mind, there are multiple molecules which came from time to time. In 1957, we had the tricyclic antidepressant, which is both serotonergic and norepinephrine. Then in 82, we had the first SSRI, Melatonin. And after that, multiple molecules of SSRIs we have. And then in 1993, the first SNRI, venlafaxine. And after that, we have two more molecules in this class. And 2009, agomelatine, which you can see it is a melatonin 1 and 2 receptor along with 5-HT2C. It was a promising molecule at that time, but did not show the promise in terms of response and remission. Then finally came vilajuron, which we thought was a new molecule. It was better on some counts, especially the sexual side effect part, but the response and remission was not adequate. Then comes our vortioxetine. Now, I showed these molecules in terms of a class difference from the previous. And vortioxetine, as you can see here, is a molecule which has polyreceptor, both antagonism, agonism, and to summarize, it is both an inhibitor for SERT, it's an agonist of 5-HT1A, which is probably responsible for the procognitive, and it is also acts as an antagonist in serotonin 3 receptor and serotonin 7 receptor, which probably accounts for the less sexual side effects. You remember we talked about this as a challenge. Now, working with this, there are probably one of the largest number of studies done before US FDA gave approval. Roughly more than 9,500 patients participated in 17 short-term studies, 3 studies investigating specially for cognition, and also few patients in 2,000 or 3,000 patients who have participated in open label long-term up to 1 year stay follow-up. And this data also has in elderly. So this is probably a molecule which is probably had a multiple trials before it is recommended. So it is recommended as an antidepressant up to 65 years and above as well, and Brintellix 10 milligrams to 20 milligrams. Very briefly about the side effects. One of the most interesting things is of the 9,000 patients who followed in the trials, there is no effect of pharmacokinetics. It is bioavailability is slowly building up, but mean half elimination time is 66 hours. That by we can give as a single dose, and approximately 2/3 are inactive. So, and drug-to-drug reaction, it's negligible, especially steady palm. So now I'll talk briefly about the next 2-3 slides on the efficacy of mood symptoms. I will first show you the short-term studies. There are multiple studies, and I'm going to show you the meta-analysis, which show that in the majority of trials, when compared to both placebo and venlafaxine, vortioxetine beats and shows, as you can see in this slide, response at the end of 2 weeks itself, as you can see here, statistically significant compared to the placebo in severe depression, and also reduces high anxiety. This is a summary slide, if you may, of almost 9 trials in which they have tried short term up to 8 weeks. And what you find is almost all the trials, as you can see in this slide, beat the placebo. This is the line, middle 0, at least 2 scores and more better than the placebo, which is sufficient for a psychopharmacological point. And what you extend coming to the anxiety scores, again, as you can see in this scale, almost most studies, especially there were some trials where they have used HAM-A anxiety scales, they found the scales that less than 2 points standard deviation, and none are worse, made worse than the placebo. So what extent improves anxiety in major depressive disorder, at least in this 6 to 8 weeks to 12 weeks trial. And then coming into the summary slide of all the studies published till this point of time, including the McIntyre, what you find is that there is a subtle difference between US and non-US studies, but the more important in non-US, there's a much larger response. And what you extend at the end of 36 weeks, you significantly find and reach more than 36%. What you extend proportion is more than 50% remission at the end of 12 weeks. Remember, we were talking about the shortcomings of the previous slides. And then there were multiple trials, at least 3 trials, which compared with patients who did not respond to either SSRI and SNRI. This is one of those studies. In what you find is those who have completed a 12-week trial with SSRI, SNRI were put to either vortioxetine or SSRI, and you definitely find that at the end of 4 weeks, this sample patient did respond, and they continue to improve at the end in both the cases. So vortioxetine significantly superior to agomelatine, and especially in SSRI non-responsive. And this is one of those trials in which elderly have been tried. Having come, so the summary of this is that vortioxetine is responsible for reduction of depressive scores on MADRS and HAM-D, and also HAM-A anxiety scores it reduces. So this is a summary of 11 trials of meta-analysis. Now, coming to the most important component, which was touched by my previous colleagues, cognitive symptoms. It is found very clearly that the emotional symptoms dominated by the cognitive symptoms, and patient functioning is affected by the cognitive symptoms. Having said that, patient comes with poor concentration, lack of focus, slow motion, no attention, confused all the time, forgetting activities of daily life. So these are the common complaints of memory, executive functioning, psychomotor speed, and attention. And what the extent trials, they have used 2 important questionnaires. One is the DSST, and second, Roger McIntyre has used the other cognitive test, what is called FST. Now, in both the trials, vortioxetine was compared to duloxetine or placebo, and you find significantly that in all the 3 different trials, including one in the elderly, which is called Ankova Fast, when they have used that, it definitely beats in the 8-week trials. This is Roger McIntyre's trials as well, where he has used PDQ as another questionnaire, comparing vortioxetine and duloxetine. There is a significant response. And this is the slide I want to show, that in most of the summary of the multiple trials, 57% of patients responded or remitted with vortioxetine and 61% on 20 milligrams. So it beats the previous gold standard to a large extent. And this is the remission, which is definitely higher when compared to the previous slide. So I would close my presentation talking very, very briefly about safety. I have Amrut, who is going to talk about that anyways. What is important is the only side effect which was found above 10% is nausea, which was usually mild to moderate, usually occurs in the first 2 weeks. And it was transient, especially if you start with a low dose and increase slowly, titrate upwards. And the most important factor is comparatively low withdrawal rates because of side effects. In fact, the entire 9,000 sample did not have any serious adverse events during or a drug overdose. This is a summary slide of all the side effects present. And what you find very interesting is headache compared to placebo is more or less same. Sexual side effects is less than 5% compared to placebo. In fact, placebo had little higher sexual side effects during the trial, and tremors and all come under less than 1%. As you can see in the red, the only side effect is nausea, and nausea is due to 5-HT1A stimulation. No body weight gain, and we do have evidence at this point of time that vortioxetine was superior to escitalopram in improving SSRI-induced treatment-emergent sexual dysfunction. Having said this, I think we have data at this point of time, last but not the least, that response occurs by the end of 2 weeks. So this is something which most of the psychiatrists are looking for. And I close with my own data. Over the period, I have over 1,000 patients, and I have used in major depressive disorder, generalized anxiety disorder, OCD disorder. In general, 50 to 60% of my patients had a good response. So that's what we hear. Thank you, ladies and gentlemen. I will restrict myself now, and I will now request O.P. Singh, the professor of psychiatry and a senior psychiatrist. More importantly, my dear friend, he is also the current vice president and president-elect of the IPS East Zone, current editor of Indian Journal of Psychiatry, who brought our lot of prestige to our journal, Indian Journal of Psychiatry, by his own contribution, increasing the gold standard to a platinum standard of the journal. He has done a lot of mental health programs across the West Bengal and the nation. He has won a lot of awards. He has authored his 82 papers published in national and international journals, and about 8 books he has written chapters. O.P. Dada is a very, very friendly person, quite efficient, quietly efficient, and I love him for his pleasant manners. O.P. Dada, your presentation, please.
Thank you, Prasadda, and this is such a pleasure to be here along with you, Gautam, Pramod Kumar, and Amrit. So I must thank you and Linux for giving me this opportunity to present on this. So, first of all, I must say that it is very easy to, how we would see that it is very easy or difficult to speak after you, because you are such a person who has vast knowledge and who have worked with this. So, with this, I have some problem in screen sharing. So I will ask Mr. Rup Kumar to share the screen on my behalf.
Sir, just 1 second. Sir.
Till the screen is shared, we are basically talking about, I will be talking about unmet needs in depression. We as a clinician, all of us are, most of us are clinician, and previously where we thought that schizophrenia is our bread and butter, but nowadays we understand that depression is maybe our bread and butter. And as my friend Dr. Gautam Saha said, though it seems easy, but it is one of the most difficult things to treat. So I will be just enumerating some of the unmet needs in depressive treatment. Dr. Prasad Rao has already covered a lot of them, but still I will try to cover and stimulate your thoughts, which we can discuss in further. Next slide, please. So, what are the problem with pharmacotherapies for depression? We need drugs with faster onset. We know that drugs, antidepressant needs time to work, and patient in our clinic are not so patient. So we have to give them relief very fast. So our wish is that we'll prescribe today and the person will start getting well from tomorrow. So that is one need, our wish list, that drugs with faster onset. We need higher remission rates. Of course, if you get a drug which do not have a side effect, the drug must have an anti-suicidal properties, so that while treating the patient, we should not lose our patients to suicide. And it should be able to work in broad spectrum of subtypes, whatever this, melancholic, atypical, agitated, chronic, even bipolar depression. So it should be effective in all subtypes of depression. It should provide cognitive benefits, durable relapse prevention. Efficacy should be persistent. We know that proof of syndrome is there with our drugs, SSRIs. Sometimes after some time, they are working very well. Down the line, suddenly they stop working. And of course, better functional outcomes. So this is the need for us for have a better drug which can meet our needs. Next slide, please.
Like this.
Already we know that depression is a clinically heterogeneous disorder. It has emotional symptoms, cognitive symptoms, and of course physical symptoms. We know, we are aware of this emotional symptoms: sadness, anxiety, irritable, lack of enjoyment, suicidal ideation, hopelessness, guilt, fatigue, weight loss, weight gain, insomnia, hypersomnia, sexual dysfunction, both as a symptom, and again our drugs may increase this. Then we have problem of attention concentration, short and long-term memory, judgment, decision making, planning, and organization. So all of these things are, so all these domains are there, and we need a drug which should be effective in all these domains. Next. So whenever the first drug which started with serendipity, iproniazide, was discovered that it has antidepressant properties, and from there we got imipramine. And it was, we know that it was reverse engineering sort of thing. That first the drug was working, then we tried to find that where it is working, and we came out with monoamine hypothesis. And till now, most of the drugs are working on different neurotransmitters and different combinations of neurotransmitters. And we still, for 70 years, still we are revolving around that. There are other theories has come, like inflammation in pathogenesis of depression. And people said that inflammation leads to activation of IDO pathways, which decreases serotonin and ultimately leads to depression. And a lot of symptoms which has been directly, sub-symptoms has also been found directly linked to inflammation. So CRP, IL-6, they are not very specific, but they have been seen, and COVID particularly, it has been found that it increases suicidal ideation, it has increased depression by their action, by inflammatory pathways in the brain. So people have, next slide please. So people have tried to develop biomarkers and other drugs which worked on these receptors. But somehow, with a lot of enthusiasm, they are not have been very successful. NK1 antagonists, CRF1 antagonists, metabolic receptor modulators. Apart from ketamine, the other NMDA receptor antagonists such as riluzole, memantine, lancimine, D-cycloserine failed to show much response. So other methods has been tried. People have tried to do research on anti-inflammatory pathways, glucocorticoid pathways, NMDA pathways, but somehow the efficacy and effect has not been sustainable, had not been clinically significant, and most of the drugs has been put on hold. Next, please. So we need drugs, particularly trials are with simple depression patients. Other people having a lot of comorbid disorders, taking a lot of comorbid drugs. We are not sure, our drugs are not well studied in those populations. So we need real type patients, real type research into that. And then again, genome studies has not been replicated. So a lot of problem is with our research, which needs more improvement. Next, please. So another problem is whether the two drugs are better. It has been found that people are using two drugs, and it has increased by 344% from 1996 to 2006. In NIMH COVID trials, it was found that two drugs are not better than one drug. So this is still a problem why people are using it, because of course people are not getting efficacy, they are not satisfied, so they go on increasing the drugs. Next slide, please. Already we have talked about cognitive symptoms. Even patients are better, the cognitive symptoms persist, and that is one of the major cause of functional impairment and also relapse. Next slide, please. So cognitive symptoms lead to negative impact, personal, financial, school, job. So it is also important to treat them. Next slide, please. So current treatments treat emotional symptoms, don't treat cognitive symptoms so well, and sometimes can worsen the physical symptoms like fatigue, weight changes, particularly sexual dysfunctions. In fact, very common, and that is one of the commonest reason for people dropping the therapy. Next, please. Next, please. We know the side effects of all the drugs. So we know we need a better integration of neuroscience with clinical phenomenology. We understand that like NIMH has said that they are not going to any trial. They are not going to approve any trial which gives only symptomatic relief. They are only going to approve research which will give some inkling how the things are working. So how the brain works, how some people fail to develop resilience, how early life stress modify brain response to current stresses, to identify new drug targets, to assist the third mode of depressed patients to respond poorly to current treatments. So we need to identify different targets. So and also we need to treat better, use better drugs. Selection should be better, and that is also required. And there is a lot of research is required in real time. So we need that clinical trials remains the cornerstones for determining effective therapies. Efforts to relieve morbidity and mortality from depression cannot be dependent on finding the biomarkers only, because it is failing. Future progress demands a more practical integration between basic neuroscience and clinically oriented research reports. Next slide. Next. Thank you. Thank you so much.
OP Dada, you have concisely put the problem very clearly and also focused on real practical issues of the futuristic depression management. You talked about the biomarkers, you also talked about the cognitive symptoms remission, and you also talked about the unmet needs quite well. And obviously bringing up into the focus this generation molecule, what you extend and how it can help. Thank you very much. Now I come to my dear friend, Dr. Amrut. Dr. Amrut, again, I would say he is the futuristic leader of Indian Psychiatric Society. That's how I call him all the time, which he would shyly say, no, sir, no, sir. And Dr. Amrut is known for his very innovative, and he is one of the author, along with Tufan Pati and Alim, who gave us the wonderful Thursday musings. Regarding Amrut, he's like my younger brother all the time, professor at High Tech Medical College. He is both a very active worker in the Indian Psychiatric Society. He's currently the honorary secretary. He has worked in multiple posts in the IPS Odisha branch, also in IAPP, IABP, everywhere, and more than 40 publications is credited. And the most exciting part of it is the organizing secretary of the ANSIPS 2023, about which we all have a great hopes. It's going to be a great scientific feast, and apart from that, much more than the scientific feast. Amrut is going to keep all his heart and mind along with all the others. Amrut, you are going to tell us the advantage of this molecule in terms of tolerability and side effects. Please, Amrut.
So much, sir. So first of all, I would like to thank Linex for inviting me for this talk. It's a very prestigious one because with me were Dr. Gautam sir, my guru, then OP sir, my mentor, Pramod sir, Prasad Rao sir. So it's a very, very honorable thing to come and speak along with this whole stalwarts. So I'll be a little fast as always. So sir, please bear with me. So coming to vortioxetine, like everybody is speaking about this new molecule. The companies are coming with this, but this is something which we have been using for the last maybe 2.5 years, 3 years, maybe around 3 years approximately. And I have not used in thousands or hundreds, maybe a couple of hundred patients I have used, and I'll be discussing the advantages I got. Whenever we have in our armaments a lot of molecules. So we always station each molecule for a specific patient population. We have acetabulum, we have sertraline, we have the TCAs, we have the SNRIs, we have the NASAs. Everywhere somebody needs weight gain, somebody needs sedation, give a NASA. Somebody has anxiety, somebody you give a SNRI. Somebody has somatiform disorders, somatic symptoms, give a TCA. Somebody is old age, give a SSRI, maybe a sertraline. So we all, every practitioner has their own armament based on where they want to fire, what they want to fire. So, and we always feel that every molecule with their pluses have their minuses. And most of the time we are dealing with the minuses more than with the pluses. So as I was talking about the efficacy, yes, if you look at molecules, it is 32 to 33% as a, efficacious. So, as a second line also, we have around 31 to 31% remission rates with most of the antidepressants. So unmet needs in MDD, like sir was discussing about, weight gain, sexual side effects, sleep disturbances. I'll be talking about certain things. So one of the most important things why patients leave us is the, adverse effects which we get. Like Dr. Pramod sir was talking about, giving a bit of psychotherapy in the starting of the, treatment. So majority of the people who come to us and who are put on antidepressants have side effects. It is on us to ask about them. It is on us to identify them, and if possible to sensitize our patients to the common side effects. And most of the time, if you can go through the first 2 to 3 weeks, if you can retain the patient for the first 2 to 3 weeks, then you have the patient so that you can heal them and you can send them as better in terms of mental health individuals. As many as 1/4 of patients discontinue this antidepressant due to difficult to tolerate side effects. So, and if the side effects are difficult, sometimes the burden of the side effects is much more than the burden of the disease. That's what many of my patients talk to me. Sir, I was depressed, it was okay, but now I'm not able to feel anything. Sir, I was, these are the common things. Sir, I'm having weight gain. Sir, I'm not able to have a good, when I was depressed, okay, my sexual functioning was a little less, but now I'm not able to have an orgasm. Before, I was not able to sleep, but now I'm able, I don't know whether I'm able to sleep or not. Throughout the morning, I feel groggy. Sir, should I take this antidepressant throughout my life? I asked, why? So I left it for one day and I have a lot of anxiety. You know, I felt worse than when I was not on medications, just because I didn't take my SNRI for maybe 6 hours or 8 hours. I skipped it. So these are the things which we need to put in our heads. Leave alone the major issues, but these are the minor things which might be minor to us, but maybe very, very big for our patients. So this is one study, adverse effect causes non-adherence and impaired recovery, which we all know. So current treatments, what we talk about sadness, we talk about anxiety, we talk about irritability, we try to take care of lack of enjoyment, like Sir was talking about suicidal ideations, hopelessness, maybe inappropriate guilt. And but if you look at the cognitive things, which is the most difficult thing, they're the attention concentration, short and long-term memory, decision making, planning and organization, thinking speed, judgment. And along with it, the other physical symptoms like fatigue, insomnia, sexual dysfunction, headaches, somatic problems in terms of chest pain, psychomotor agitation. I see a lot of sweating when it comes to SSRIs, SNRIs. So these are the things which we need to handle every day in and out. So current drugs treat the emotional aspect, can worsen the physical aspect, but don't treat the cognitive aspect. So to meet the unmet need, vortioxetine, like Sir was talking about partial, it's a agonist at the 5-HT1A receptor, partial agonist at the 5-HT1B receptor, and antagonist at the 5-HT1D, 5-HT3, 5-HT7 receptors. So if you look at the major neurotransmitters involved, serotonin, it increases the serotonin level, glutamate, noradrenaline, dopamine, acetylcholinehistamine. Only it enables the GABA. So it almost acts on all the neurotransmitters. But if you look at SSRIs, which is the most common antidepressant drug which we use, it increases the serotonin and it increases the GABA. So if you look at the mode of action, it's multimodal. It involves everything. So if you look at major depression, it is wonderful drug. Elderly patients, the caveat with elderly patients is don't go higher than 10 milligram per day. So if you're going, if somebody is above 65 years of age, go slow, go low. That's what we do with all molecules, even with vortioxetine. The best is start at 5, go up to 10 milligram. Sometimes we may need to go to up to 15 milligram. Pediatric population, again, the safety and efficacy of in children and adolescents in less than 18 years have not been established. It is safe in mild to moderate renal impairment, and it's safe in mild to moderate hepatic impairment. So those are the advantages, almost similar to acetylopram. And if you look at sertraline, which we use in old age, even vortioxetine can be used in old age. If you look at, old age, if you look at the population above 50, 55, even if you look at population above 45, most of us are using 1 or 2 medicines. And as our age grows, sometimes people tell us, I don't have anything for breakfast, sir. I only have my 21 pills. So that is what we have to be very, very careful when we prescribe our medications. Because if anything happens to our clients, the first culprit will be the psychiatrist and the psychiatric medication. They'll just tell this medication caused this. So we have to be very, very careful about what we prescribe and what are the indications or interactions of the various drugs which are given. So if you look at the interactions, vortioxetine is one of the safest drugs to use. So the only contraindication is to use with a MAO inhibitor or a selective MAO inhibitor. So based on individual patient response, a lower dose of vortioxetine may be considered if a strong CYP2D inhibitor like bupropion, quinidine, fluoxetine, paroxetine is added. So if you are using a fluoxetine or fluoxetine, maybe a lower dose of vortioxetine may be used. In pregnancy, it is limited data. Breastfeeding also, there is limited data. So if you look at efficacy, like Sir had discussed, it is good for depression. It is good for patients with depression with anxiety. It is effective in reducing depression symptoms in elderly above 65 years of age. That is one advantage. My first choice always was sertraline, but after the use of vortioxetine, I have added another molecule to my arsenal. So the most important aspect where vortioxetine, we might be able to put in vortioxetine is the cognitive symptoms. Now, if you look at the major molecules like vortioxetine, and most of the trials of vortioxetine have been done with duloxetine. If you look at modafinil, I use a lot of modafinil for cognitive symptoms where people talk about not able to focus not able to, being very dull. So if you look at the trials, so one is replicated placebo-controlled trial evidence with demonstration of independent effect. So vortioxetine takes the cake. So in learning and memory, it has good, robust evidence for attention and concentration, for executive functioning, and for processing speed. In all the 4 domains, I think vortioxetine scores above all. If you look at duloxetine, for learning and memory, it has good evidence. If you look at modafinil now, I actually now I've started using vortioxetine more when there are cognitive deficits, and I was using a lot of modafinil, and I'm trying to change my track. So if you look at other SSRIs, SNRIs, bupropion, again level 3 evidence, which is uncontrolled evidence, lacking placebo case series. So the most robust evidence and among all the domains is with vortioxetine. So this is the DSST, digit symbol substitution test. So it looks at the severe cognitive domains affected with MDD. So executive functioning, psychomotor speed, attention, and working memory. So across all the 3 trials, connect, focus, and elderly. This is the elderly trial, vortioxetine versus duloxetine. Focus was vortioxetine 10 milligram versus vortioxetine 20 milligram, and the connect trial was vortioxetine 10 and 20 milligram with duloxetine. So they found that vortioxetine scored, it had the best, results. Even if you look at daily functioning, which there is the UPSA, the household codes, communication, finance, transportation, planning, recreational activities, vortioxetine, if you compare it with placebo and duloxetine, has the best response. So unequivocally, we can tell that vortioxetine, when it comes to cognition, has the best result. It improves mood, cognition, and functioning in MDD. And one of the best things about vortioxetine is, irrespective of the changes in the mood state, there is change in the cognitive domain. It is not the improvement in the cognitive domain is not just because of the improvement in the depressive symptoms, but it is more to do with the effect on the cognitive domains. So if you look at the comparison with other drugs, vortioxetine with SNRIs, SSRIs, MAO, TCAs, vortioxetine has brilliant effect in terms of cognitive improvement. So if you look at safety and tolerability of vortioxetine, I think this slide summarizes the beautiful side effect profile of vortioxetine. Vortioxetine is at the lowest end of the trial. The only major issue with vortioxetine is nausea, and I'll be fair enough to say that I have had a few discontinuation with vortioxetine with related to nausea. If you look at constipation, if you look at diarrhea, which many times we find with our SSRIs, dry mouth with TCAs, dizziness, initial part of whatever antidepressant treatment we do, somnolence, nervousness, anxiety. People ask me, sir, I had come to you for my treatment of anxiety, and we have increased it with your treatment. Agitation associated with the anxiety and nervousness, insomnia. If you look at fatigue, if you look at sweating, major issue with a lot of SSRIs I see. Asthenia. If you look at tremor, if you look at anorexia, if you look at increased appetite, again, this is a very, very important issue, because we have a lot of people nowadays who are working people who don't want to increase their weight. Weight gain is very, very less. And if you look at sexual dysfunction, so the only parameter is, if you look at vortioxetine, is nausea. And the next molecule which can challenge vortioxetine in terms of the side effect profile is acetalopram, which causes a little bit of nausea and male sexual dysfunction. And that is where vortioxetine scores over acetalopram. Rest all, they're similar, but when it comes to sexual side effect, vortioxetine is much better. So vortioxetine does not exhibit many of the side effects typical of SSRI, like Sir was describing about weight, low withdrawal rate and discontinuation symptoms, sexual dysfunction, sleep disturbances, low potential for drug-drug interactions, low rate of treatment emergent adverse effects, low rate of safety-related adverse events, and mild to moderate transient nausea, which is little, you have to take care of that. Another issue is vortioxetine for MDD patient with trauma. This is one aspect. We see a lot of people now, young people, who come with a lot of trauma in their childhood. It may be death of post-COVID. You're seeing a lot of people who have had trauma in terms of losing somebody very close, being in the ICU for long, being in isolation for long. Now, parents staying together, a lot of loss of jobs, a lot of traumatic sexual experiences. Nowadays, we see a lot of people being sexually abused, victim of violence in terms of, be it abuse, be it sexual abuse. People are handling a lot of illness. So if there are major changes in work from home, people are, these things, in these things, vortioxetine has been found to be little better than many of the other drugs. So highlights is we can treat patients with severe depression, high levels of anxiety, elderly patients now. Apart from SSRIs in terms of a sertraline and acetalopram, we have now vortioxetine, which we can, because now people are living for far longer. We have a lot of people, if you look at number of suicides in this pandemic, above 60, 65 is the highest rise of suicides. So here people with depression might be, we have another armament in terms of vortioxetine. Patients with suboptimal response to one SSRI or SNRI treatment, it improves all 4 domains of cognitive symptoms, very mild or moderate adverse effect, low withdrawal rate, and sexual dysfunction during vortioxetine treatment, 5 to 15 milligram dose was low and similar to placebo. But when you increase the dose to 20 milligram, there was a lot of treatment emergent sexual dysfunction. So in a lot of patients who come with sexual dysfunction with SSRIs, sexual dysfunction with SNRIs, NASA, I have started slowly moving to, initially vortioxetine was very, very expensive. So you have to think, should I give a, sildenafil along with the antidepressants? What is the cost involved? Now it is much, much easier. We can always think of giving vortioxetine if somebody is having sexual dysfunction, somebody is young, somebody is sexually active, somebody wants to have a baby, somebody is not having orgasm. I see a lot of people on fluoxetine talking about anorgasmia. I think here, if you look at desire, if you look at performance, if you look at orgasms, if you look at libido, I think vortioxetine is much, much better. If we have a molecule which does not cause weight gain, which is absolutely a broad spectrum one, which helps in the cognitive domain, which helps in the sexual domain, I think it is absolutely a brilliant drug. So it's a good antidepressant efficacy, good tolerability, once daily dosing, it is evidence-based, low drug-to-drug interaction potential, weight neutral, sleep neutral, no sexual, almost minimal sexual side effect concerns. It improves cognition, cardiac profile is good. Even in diabetes, if you compare to sertraline to a vortioxetine, it improves the glycemic control. That is another important thing. We can give it from adolescents to adults to elderly people. Pricing concerns are now removed. GI and nausea as side effect, troublesome at times. So depression is not a sign of weakness. It means you have been strong far too long. So please start treatment, get better. Thank you so much.
Thank you, Amrut. I think, first of all, I would congratulate you, because I think this is one of a comprehensive, last 2 slides actually speak everything what you wanted to speak. But the way you presented in a very gradual, progressive way, the difference between this molecule and other molecules currently available, with a tongue-in-cheek responses at each point of time. This is an alternative molecule. Whenever we want to use, we use it. And I am particularly thankful to OP Singh, Pramod Kumar, and Gautam Dada for their inputs. I think all the 4 panelists together, we have covered quite a lot of topics. Now, may I open with these questions? There are a lot of questions, but I'll start with the first question. There was a question by Dr. Yusuf Khan asking whether vortioxetine is safe in dementia. I think he meant depression in dementia. I would request OP Singh to talk to this, respond to this. Dementia and depression, whether vortioxetine is safe.
There is no such trial I am aware of, which is in depression and dementia, but already it is safety in geriatric population is established, and it is effective in geriatric.
Yeah.
So
yeah. You are absolutely right. I think its efficacy, I think there seems to be some connectivity problem to OP Singh. What he told clearly is
that it's not be
Sir, it is in PhD, it is helpful, sir.
It is helpful, yeah. See, I would say from my side, of late last 4 years, BPSD is the area of my research, and I find a lot of patients. And vortioxetine can be very safely used, especially with the beautiful drug-to-drug interactions, as detailed in Amrut's presentation. The almost no contraindications. There is one more question by again Yusuf Khan, and now I would ask Gautam Dada to answer this. What is your experience on diabetes mellitus and hypertension? The safety of vortioxetine. Of course, Amrut has already said it's a good.
Yeah, it has already mentioned diabetes. In fact, it is helpful rather, and also as such, there is no contraindication in prescribing vortioxetine in patient with diabetes or hypertension. So it can be prescribed very safely, and especially when we are choosing this molecule in the elderly populations. And it is definitely we can prescribe, and it is nothing, no contraindication, nothing wrong in prescribing this. Rather than it will be helpful to this if you see that.
There are a lot of congratulatory words for each of the speakers, but there was one very interesting question. What are the contraindications of vortioxetine? I would now ask Amrut to answer this. I will answer in the end, of course, but Amrut, is there any contraindication of vortioxetine?
Contraindication in terms of severe renal failure, sir. If it is not, if it is mild to moderate, it is okay. But once it is severe hepatic impairment, severe renal impairment, you have to be very, very careful, or maybe you might not use this drug. Along with MAO inhibitors, you should not use this drug, sir. And in cardiac failures and all, you have to be little, because if you look at trials, it has no effect on the systolic blood pressure, diastolic blood pressure, even the pulse rate. But if there is a severe congestive cardiac failure and all, you have to be, you have to take care of that. Rest you can say add.
You are absolutely right. I think you added all the four important red flags where we have to watch our patients. But I would add one more. What is described as sensitivity to vortioxetine, though there are no cases reported, any of our patients, if they are known to be sensitive to vortioxetine, naturally we don't use. There is one more question. Is there safety in pregnancy and lactation? I would again ask my dear friend Amrut to answer this.
I have presented these slides, sir.
Yeah. Both of us presented these slides. I also, you also. I think the answer is very simple. Right now, we still need data to really recommend, but
very limited trials.
Yeah, we don't really have trials. There is one more question asked by, again, little critically. Is this a pro-sexual drug? Who would take this hand? Amrut will take the hand.
Yes, sir. Because one of the major, I had all the bases covered when I was treating my patients. Two bases were not covered: cognitive domain, which I was not very, very particular about, because sometimes I would tell that maybe you are improving, it will take time. But the sexual side effects have been the most important thing. Sexual side effects, even in terms of somebody having sexual impairment before the onset of the depression. Now I started, and after even the depressive symptoms have improved, 5 or 6 of my patients want to be on these drugs, sir, because it improves their sexual functioning. So that is where I have been able to put it. It might be rational, it might be irrational, but once if your patients are happy and they're asking for it, and there are no major side effects, and their life is going smoothly, I think I have used it as a pro-sex drug, and rest my gurus will tell. OP sir can tell.
OPG and Gautam Dada.
I cannot say on that, but of course, sexual side effects are one of the major reasons for which patient drop from the treatment. And all SSRIs now, people are talking about 40 to 50% to even maybe higher than that. So if these effects are not there, and after the improvement of depression, sexual life improves, so it may be considered like that. So it is a huge improvement on that.
Yeah, I agree with Gautam Dada.
I am also in that.
Gautam Dada.
It cannot be told as a pro-sexual, because it is any sexual disorder. For any sexual disorder specifically, you should not write this medication. But at the same time, I must say that people with depression, with sexual side effect due to SSRIs or other medications, And definitely patient have what Dr. O.P. Singh mentioned. If the patient have yes.
What you
And also the patient have the any sexual side effects due to medications, then definitely it should be prescribed or irrespective of that any molecule.
Thank you. I think there are a lot of comments saying that we have covered almost everything about what extend by the 4 faculty, and I congratulate each one of them. I would also like to add just 2 more from my side. One, we should thank people like Linux who are giving the molecule at a much cheaper when compared to the old rate. And because of this, I think there will be a huge thing. The second important thing is that though it's a new horizon, and as told by my faculty, all the learned faculty, that it has no sexual side effects, no, it has pro-cognitive drugs, it doesn't cause much side effects except the nausea, and more important, the tolerability is good and efficacy is good in generalized anxiety, depression, severe depression, mild, moderate depression, and whatnot. I would only add a little blank of caution to in the end. It is not an all panacea drug as yet. It is a molecule which is better in many sense. And I would request Linux that 6 months or 9 months down the lane, we'll have an experience sharing because this molecule will be available to all the Aam Aadmi people. And the cost is almost comparable to SSRIs or even slightly cheaper than SNRIs if you take the other polypharmacy things. So I first of all thank Linux for giving the opportunity. And as I understand, it is a few thousands are watching. And I also take time now to congratulate each of the 20 hybrid centers, the chairpersons. Roop, can you quickly show the slides of all the centers, because we have initially did not show it. As I say this, I thank the wonderful participations and the questions. There are a lot of questions which are all similar in nature. I didn't take anybody's name, but the basic thing everyone said that this is a good sexual drug. And as I said, is there any important issues with this molecule? And we covered, I think all the faculty has covered all the topics, especially Amrut has covered very nicely. Now I would just close to start with one after other, the faculty members who are chairing the sessions, Dr. Ramakrishnan from Palakkad, Rajarshi Niyogi from Calcutta, P.D. Garg from Amritsar, and we also have Dr. Gopal G. Kar from Cuttack, and the next Dr. Shivanand Manohar from Mysore, my dear friend, Dr. Sanjay Jain from Jaipur, again a wonderful friend, Sanjay Gehlot from Jodhpur, again I know him for his wonderful interactions, Pankaj Verma from Safdarjung, Shivanand, and all of them have conducted the sessions. And finally, Kamlesh Dave from Surat, Rahul Kumar from Chandigarh, and Shankar Nirmal from Pune, and then Narasimha Reddy from Visakhapatnam, and Kishore Kumar from Tirupati. So down south, we had a lot of centers. Any more? Did we miss out anyone, Rup Kumar? Anyway, if I missed out.
No. We have covered everybody.
Yeah. So thank you very much, each one of you. And I'm sure this is going to be a molecule to be tested by each one of you. And I would definitely hope that Linux will come back within 9 months to 1 year of a real world experience by the psychiatrists across the country. Thank you very much. Over to Rup Kumar.
Thank you very much, sir. Thank you very much, sir. At the outset, we promise we will come back to you after 9 months with a lot of real world experience. We have had a massive program today. Almost more than 1,000 doctors have participated. So with the real world experience, we'll come back and have another major conference, sir. So with this, I also take the pleasant task of giving the vote of thanks. First and foremost, I thank Dr. Prasad Rao, sir. Without him, to putting this entire program into place, step by step, he was there with us. So I thank Dr. Prasad Rao, sir. Thank you very much, sir. And it is a great honor. Dr. Gautam Saha, sir, is chairing the session. Sir, thank you very much. We had brilliant speakers today, Dr. O.P. Singh, sir, Dr. Amrit, sir, and Dr. Pramod Kumar, sir. Thank you very much to all the speakers today. And as far as the chairpersons and the moderators of the 20 centers has been already, Dr. Prasad Rao sir has highlighted. So thank you very much for partnering with us in this program. And so a lot of very, very happy activities has happened across these 20 centers of the cake cutting. Being participating in launching this Vertica, Vertioxetin. And these are all the, participation across the country. Jaipur, Jodhpur, Surat, Varda, and then we have in Calcutta, Surat, and Cuttack, Mysore, across the country. All these things are the participation. Thank you very much for coming and participating in the program. Last but not the least, it's my duty to thank my team, sales team across the country who has been working on this for the past 10 days to put this program into place. As I said, more than 1,000 doctors have today participated. And very importantly, I would like to request your esteemed support for Vertica, which is available as 5, 10, and 20. It is very, very affordable, as Prasad Rao sir said, and it is very much available across the country. Length and breadth of the country, it is available. And with 15 years of dedicated service of Linex, we are reaching to more than 50,000 healthcare professional doctors across India. And reaching out to 10 million patients across India. And also, we have started our international operations and a very robust distribution channel of making our product available across the country. So with this, I thank all of you very much. Vertica means journey of joy and happiness. Thank you very much and good night.
And I would thank Vijay Kumar for his silently participating, and request Vijay Kumar to see that his talks are getting exhausted very soon. So I think there's a lot of work for Vijay Kumar, Rup Kumar, and everyone.
Yes, sir.
To see that the supply chain is maintained quite well.
Definitely. We'll take care, sir. Thank you, sir. Thank you so much. I do want to thank Prasad Rao sir for helping so much. I do extend my thanks to OP sir. I also want to thank Amrit sir and of course Gautam sir to helping us and spreading this scientific feast to entire country. Thank you so much, sir.
Thank you. So we leave. Good night.
Thank you, sir.
Good night, sir. Good night, sir.
Good night, everybody. Good night.